Hi, welcome back to my channel. Today I want to take an analysis of a recent New York Times guest essay that came out that I found quite provocative, and it is titled, "Organ Donors Are Too Rare. We Need a New Definition of Death." This article is authored by Dr. Sandeep Jauhar, Dr. Sneha Patel, and Dr. Deanne Smith. Dr. Jauhar is a cardiologist at Northwell Health in New York, whereas Dr. Patel and Dr. Smith are the directors for the Center of Heart Failure and Transplant, I believe, at that institution. So in this article, Dr. Jauhar, Dr. Patel, and Dr. Smith put forward a proposition of changing our definition of brain death, or what we call death by neurologic criteria. And as I mentioned, I found this article extremely provocative and very close to my heart. I am a critical care neurologist who spent the better part of the last decade dedicating myself to the care of children with serious brain injuries. I have been involved in the performance of formal brain death testing, or what we call death by neurologic criteria. I know the process very well, and I take it extremely seriously. It is these cases are usually devastating and completely awful, and this is work that is challenging and is emotionally intense for everyone involved, and they take it pretty seriously. And it's a responsibility that we have in moving forward in the face of catastrophe for the patients and the loved ones that are having to go through a situation like this. I also take care of children who are in coma from serious brain injuries. I have experience with that, and a lot of mixed emotions about my experience in doing that. And but I've learned quite a bit, and have found the overall process extremely fulfilling. And I am involved in research where we investigate for consciousness or signs of consciousness in children who are in a coma. And I also, as you know, with this channel, just have a robust interest in philosophy, living the examined life, and thinking about these sort of issues from a philosophical perspective. So with all of that in mind, this was kind of the perfect article for me to tackle at this time, just because it brings all of this stuff together. So let's dive in. I want to put forth that the views and opinions expressed in this post are solely my own and are not representative of any organization that I am affiliated with. This content is intended for informational, educational purposes only and is not medical advice. Always consult your physician or medical professional for any medical concerns or treatments you may have. So the authors address the operational process in a hospital by which patients are declared dead, and they do this accurately. So they describe that there are really two ways in a hospital where a patient is declared dead. It occurs either if the heart stops functioning, or we do a thorough evaluation through brain death testing, or the death by neurologic criteria examination, to evaluate and come to the conclusion that the brain has suffered irreversible and catastrophic injury from which it cannot, which has led to all loss of brain function. So they do a good job of describing that there are two different ways of doing this. What they don't do is they don't go through the in-depth analysis of describing what brain death testing is. So the American Academy of Neurology has put forward in their most recent guidelines published in 2023, a characterization of death by neurologic criteria, or brain death, and that is the permanent loss of all brain function of the entire brain, including the brain stem, in a patient who has suffered and sustained catastrophic brain injury. Now, this characterization and the proper process of performing an assessment for death by neurologic criteria has been endorsed by the American Academy of Neurology, the Society for Critical Care Medicine, the American Academy of Pediatrics, the Child Neurology Society, and Neurocritical Care Society. So it is a very rigorous process. It is done, it is intended to be done in a very strict manner and with high rigor. And when in the characterization of death by neurologic criteria as a permanent loss of all function of the brain and brain stem, the term permanent is used to indicate that the function of the brain will not resume spontaneously and that medical interventions are not capable of restoring brain function. So it's really, we're talking about irreversible, catastrophic loss of all brain function. So this definition is extremely important. It's not gone over in the guest essay, so there's a lot that's left undiscussed and unanswered about what it means to redefine brain death. So to determine brain death, we do a very, very rigorous clinical assessment. And one of the things that we have to do with this assessment is we have to exclude confounding variables. We have to exclude the possibility of temperature abnormalities, of metabolic abnormalities, of any confounding medications that might have been in the system that could limit or impair parts of the neurologic exam. We also have to make sure we have established that a mechanism of injury is there. So that helps us understand that this is truly irreversible. We have to establish the mechanism of injury that's there. And then we perform a very complete neurologic examination. And this exam has to demonstrate a number of things, including one, lack of arousal or awareness to maximal external stimulation throughout the head, face, body, and trunk. Number two, fixed non-reactive pupils. Number three, absence of corneal, oculocephalic, vestibular, gag, and cough reflexes. These are reflexes of that represent brainstem function. We want to see no facial or limb motor movements that are in response to pain. Now, we want to exclude spinal reflexes, which can occur, but otherwise just no legitimate responses to pain. And then the absence of spontaneous respirations during a standardized apnea test where we provide adequate hypercarbia and acidosis to really challenge the brainstem and make sure that there is no response to any sort of respiratory function. So this is a very, very, very thorough exam. Now, there are situations sometimes where certain portions of the exam cannot be performed safely or cannot be feasibly fully completed. And in those sort of situations, we might use an ancillary test such as single photon emission computed tomography, also otherwise known as SPECT. And this can be used to support the diagnosis by looking for the presence or absence of cerebral blood flow, although these ancillary tests don't directly look at brain function itself. So it's really important to note that we need to perform that rigorous exam, and it is extremely rigorous. And when we do it in children, it's also done by two separate clinical providers and two separate disciplines, and oftentimes an institution, it's who need to show and verify that they get the same results, that there is no evidence of any brain function. When we perform the brain death test or death by neurologic criteria test appropriately, a proper assessment has never resulted in a documented false declaration of death. This is really important to know. This is part of our process of ensuring that what we are doing is rigorous, appropriate, and we are holding ourselves to a very high standard when we perform this exam. There are documented cases where improper assessments of brain death or death by neurologic criteria have resulted in a false declaration of death. But when these situations have been examined, they're usually the exam has not been done properly. The confounding variables have not been excluded. Metabolic derangements may be there. Sedative medication may not have been completely taken off. So these are situations where we are not thorough in our examination. So that's why we take this exam extremely seriously. We really make sure that we are doing an appropriate assessment before we are going to declare death by neurologic criteria. So back to the original article, the authors started by focusing on a legitimate problem, and that is organ donation. Indeed, there are urgent needs for organ donation, as every day people die waiting for an organ transplant. If an individual is an organ donor, they undergo organ donation after they are declared dead. Organ donation can be performed from organ donors through donation after circulatory death, where the heart stops functioning. But organs from people who die this way are often damaged, suboptimal, and many times unsuited for transplantation. The heart has stopped, and there is a process to rapidly procure these organs when they're maybe experiencing ischemic damage from having a lack of perfusion. So that is a legitimate problem. In current practice, death by neurologic criteria is fairly rare. It's in the authors point out that in New York, where the population is 20 million, there are often, on average, less than an annual 500 cases suitable for organ procurement and transplantation. So they correctly acknowledge that there is a gap that and that creates a real challenge for those who need an organ. This problem is real, and it's worth trying to address. The authors describe a new way of improving donation after circulatory death, which is referred to as normothermic regional perfusion, where doctors can take a donor off life support long enough to determine when the heart has stopped functioning. And then they place the donor on a device that circulates oxygen-rich blood throughout the body to preserve the organ. This procedure might have the potential to reanimate a lifeless heart. Some individuals think that this is unethical because it nullifies the reason the patient was declared dead, and that is the loss of heart function. It's at this point in the article, after they describe what normothermic regional perfusion is, that I think they start to go a little haywire and I start to get provoked. So the authors put forth that death by circulatory arrest occurs in patients who are in an irreversible coma with no hope of independent functioning. And that just because there is so much debate about whether normothermic regional perfusion revives a person versus just their organs, that we have a need to redefine brain death. I emphatically disagree with this, and I'm going to put forth the scientific and philosophical rationale here. One issue is death by circulatory arrest does not only occur in the setting of irreversible coma. Normothermic regional perfusion is currently used in patients with death by circulatory arrest, but not in death by neurologic criteria. The authors state that the procedure is used in patients who are in an irreversible coma. There may be situations where this is the case, but it would be really wrong for them to make that assumption that death by circulatory arrest only occurs in patients who are in an irreversible coma. The lay public needs to know this, and the authors do not go into it, which is really disappointing. Some patients may have what we call a biologic futility, where an organ other than the brain is failing. The heart, the liver, they might have multi-system organ failure. They may have irreversible cancer, and the patient or their surrogates may wish for a peaceful death at that point. There are many situations where a peaceful death is desired by patient surrogates because of a high likelihood for a poor prognosis. There may be a living will, and for which the poor prognosis is not specific, however, to an irreversible comatose state. These are situations where families, after a brain injury, families may feel that what they think or what the doctors think is going to be what they look like, and what in the next 5 or 10 years may not be in line with that loved one's quality of life that they would want to continue living, and so they have to they may in those situations make the difficult choice to withdraw life-sustaining therapy. So these may not always be situations where it's an irreversible coma. This may be situations where a patient is dependent on machines and they have sort of declared beforehand that they would never want to live that way. And then with children, it's just a lot harder because children don't have almost unless they have a terminal illness, they almost never have a living will, and so families and parents have to take on that, making that decision themselves, which is incredibly hard. It's one of the most challenging things I see parents go through, and we have to respect them in that process because it is perhaps the greatest decision they're going to ever have to make and the most courageous decision they're ever going to have to make for their child, which is unbelievable. Another important thing to address is that we are currently really bad at predicting recovery from coma. A key part of the neurologic prognosis of brain-injured patients is determining whether patients will recover from coma. Coma often occurs in acute brain injuries such as traumatic brain injury, cardiac arrest, central nervous system infections, arterial ischemic stroke, intracranial hemorrhage, as well as a host of other etiologies. Across all pediatric and adult guidelines that exist for neurologic prognostication, there is a lack of level A evidence, the highest level of evidence, to show that any individual test or examination finding accurately predicts long-term neurologic recovery. There are increased efforts to try to improve upon this. We are working on it with improved science, and we are trying to get better and better. The Neurocritical Care Society has launched their Curing Coma campaign in an effort to tackle key clinical and scientific knowledge gaps that remain in coma science. Nevertheless, at present day, the rigor of our data is still very poor. So if existing data to predict recovery from coma is poor, why are we trying to redefine death to irreversible recovery of coma? We are not there at all right now to be able to do this. The other issue we have to address is something that has been referred to as the self-fulfilling prophecy of early withdrawal of life-sustaining therapy. This is a phenomena where a poor prognosis leads clinicians to withdraw or withhold life-sustaining interventions, resulting in a death that may not have occurred had aggressive therapy continued. This process reinforces pessimistic prognostic beliefs, as observed outcomes, that is, death by withdrawal life-sustaining therapy, are then used to validate the original negative prognosis, even though true potential for recovery may remain unknown. This is particularly problematic in many cases of brain injury where prognostication is often uncertain and subject to bias. Studies have shown that after brain bleeds or traumatic brain injury, the decision to withdraw support is the strongest predictor of mortality. Inclusion of patients who experience withdrawal of life-sustaining therapy as a variable in clinical outcome model studies negates the negative predictive value of other clinical factors that exist in predicting clinical recovery from coma. A recent JAMA Network Open article that was published this year in 2025 showed that among 1,431 patients who experienced cardiac arrest and died due to withdrawal of life-sustaining therapy, an independent review by international experts identified that 913 of those patients, which is 63.8% of them, were believed to have had a chance for recovery had life-sustaining therapies been continued. We are obviously not doing our best. We are doing the best we can with the science we have, but we're not accurate. We just aren't accurate right now at this time, and we have to acknowledge that. And we have to also recognize these phenomena and these sort of opportunities for bias that can occur when we try to use tests that we don't know are perfect to be able to tell us that a patient's going to have an irreversible loss of coma, and implement them and be sure that those tests are actually accurate. A lack of rigorous data and the self-fulfilling prophecy of withdrawal of life-sustaining therapy have made one thing abundantly clear: recovery from coma is poorly understood. As a neurologist, I have been trained through medical school and residency regarding etiologies of a variety of neurologic diseases. In terms of coma, I have been trained to approach the diagnosis and identify etiologies to a patient who presents in the comatose state. I'll be upfront that at present, medical school and neurology residency spend a significant amount of time teaching residents and medical students about neurologic disease and disease states, but not so much time for teaching medical students and residents regarding the fundamental underpinnings and controversies that exist regarding consciousness. Contrary to what one might derive from the New York Times article discussed here, we still have a lot to understand and figure out about consciousness. We still have hard questions with poorly fulfilled explanations. What is consciousness? Can it be measured? Can it be simulated? What frameworks can help us in our responsibility as clinicians in the neurosciences to navigate through this evolving landscape? A fascinating element to the question of what is consciousness is despite centuries of exploration from great minds, we still do not have an answer. Our earliest concepts of consciousness come from the ancient cave drawings, where we found evidence that pointed to some of our early ancestors recognizing a separation of dreams and the mind. Rene Descartes brought this idea to a more refined idea that became popularized as dualism. His ultimate gift was deducting a statement of evidence, cogito ergo sum, or I think, therefore I am. Materialism has emerged in the post-Enlightenment period as a means toward better understanding consciousness. The advent of the scientific method has accelerated our use of inductive reasoning to create hypotheses, observe empirically, and rigorously experiment to create better explanations to our core fundamental questions. As we progressed in our understanding of the nature of consciousness, materialism has taken hold and offers us progression and better explanations to questions surrounding consciousness and the problems that arise from it. It is from this that we have gained an increase in understanding of the neurologic correlates of consciousness. Over the course of the last several decades, advancements in both neurophysiology and neuropsychology have allowed for the maturation of a variety of different theories of consciousness. These include higher order theories, recurrent processing theory, information integration theory, and global neuronal workspace theory. Each of these theories have been backed by fairly rigorous experimentation looking at how dynamic and resting brain networks interplay to allow for qualitative conscious experiences, memory, processing, subliminal mental processes, and the overt conscious access of stimuli that are around us. These models often overlap and conflict with each other, and its scientific champions each engage in rigorous debate with each other. When tackling these theories, however, we may come back to the statistician George E. Box, who said, all models are wrong, but some are useful. Each theory is like a blind man feeling the elephant, recognizing a part but not the whole of a true model of consciousness. In the neurocritical care environment, advancements in experimental testing and neurophysiologic and neuroimaging studies have allowed us to identify covert consciousness, or what is sometimes referred to as cognitive motor dissociation. These represent phenomena in which patients with severe brain injury who appear otherwise unresponsive on a standard neurologic examination actually have evidence on functional neuroimaging or electroencephalographic studies for willful brain activation in response to willful commands. This can also be assessed with passive tasks where tones are played at a certain pattern, and deviation from specific tones can elicit what we call event-related potentials, some of which are responsible for either unconscious or conscious processing of novel stimuli. These biomarkers, across multiple studies, appear to be associated with recovery from the comatose state. Nevertheless, in the majority of these studies, the investigators note limitations in detecting false negatives, as there are a number of patients who have a lack of positive biomarkers for covert consciousness or cognitive motor dissociation, yet they go on to have good, robust functional recovery. The critical care environment can be a very chaotic environment. Medications are being used and sedation is being used. Patients experience delirium from lack of sleep-wake cycling. Blood pressures can fluctuate quite a bit. Brain swelling can change brain networks. There are just opportunities for robust changes in brain network. And this sort of environment can make the reliability of these sort of tests to be fairly limited, at least in determining false negative results. And at current state, we have to note that these new emerging techniques, while as exciting as they are still largely in the research realm. I do research in this domain myself. We do this testing under an IRB and not as standard of care where I'm at. So and I think almost all medical centers approach this the same way in the United States. So if we are currently imprecise in determining whether an unresponsive patient has covert consciousness and whether an absence of a biomarker for covert consciousness truly represents that they're going to have irreversible loss of coma or the inability to recover from coma, if we don't have that ability, then how can we expect it right now to predict irreversible recovery from coma? This is something that the technology is not showing us that we have the ability to do. The Scottish philosopher David Hume is famous for developing what is known as the is-ought problem. In Book 3 of A Treatise of Human Nature, he writes, "In every system of morality, I am surprised to find that instead of copulations of propositions, is and is not, I meet with no proposition that is connected with an ought or an ought not. This change is imperceptible, but is, however, of the last consequence." This is where Hume states that moral philosophers often derive normative claims, the ought, from factual statements, the is. Later philosophers like G.E. Moore attributed this to what he referred to as Hume's guillotine, the idea that you cannot logically derive an ought from an is. In this New York Times essay, Dr. Jahar and colleagues fall right into Hume's guillotine. They correctly note a factual problem, the is. There is a deficiency of organ procurement and transplantation relative to the need that we have in the United States. Their normative claim, the ought, is to change the definition of brain death. This is an attempt to be logically derived from the deficiency without addressing the validity of the existing definitions of or characterizations of brain death. Just because we have a need for an increased rate of organ transplantation does not mean that we can fundamentally change the ground truth and definition of brain death, changing from irreversible loss of all brain function to irreversible recovery from coma. Over the past 5 years, there has been an unbelievable rise in distrust by the public of the medical community. I don't think in my career I have seen this degree of distrust by the public rise regarding clinicians who work in medical environments and medical centers. This feeling of distrust is backed by recent surveys that show such a rise in distrust after the COVID-19 pandemic. We physicians are quick to discuss with our vast amount of training that we've undergone to be experts in our craft, and we certainly have done a lot of training. We have some legitimate frustrations with inaccurate medical data that exists and propagates in the community. Nobody can deny that doctors work hard in their training, gain significant skills, and try to do what they think is best. But everyone, both clinicians and the lay public, have to find grounding in what brings us together. And I think that is a philosophical understanding of truth and logic. The proposals from the authors of this New York Times guest essay take a step back in gathering such grounding. The public trusts us as clinicians to tell the truth. We have a responsibility to be honest and transparent with our patients, and I think that responsibility is more important and fundamental than any large-scale problem of resource allocation that we see within the medical system. I worry that over the last 5 years, the mistrust that has developed between the public and the medical community is a reflection of the degree to which the public has perceived that the medical community prioritizes the sustenance of the medical system over patients' individual sense of agency and autonomy as it relates to their health. The problem of organ procurement needs to be addressed, and I think that both clinicians and the lay public can come to a shared understanding that it needs to be. But this won't happen by telling the public that we can change a definition just because of a need. That's logically not possible, and the public sees that for what it is, manipulation. As Bertrand Russell has said in his book, Problems of Philosophy, the truth or falsehood of a belief depends on whether the belief corresponds to a fact, not upon any other circumstance, however useful the belief may be. Distrust grows within communities when we forsake truth for utility. I hope you found this video insightful and useful. If you did, please like this video and subscribe to my channel. I look forward to talking to you again soon.